Bismillah ar-Rahman ar-Rahim. Our practical lecture will be on ECG in practice, part 1. The objectives of this lecture will be how to read the ECG tracing and how to interpret the ECG. As you know, the isoelectric line is the baseline of the ECG. The electrical depolarization of the ventricles leads to sharp deflection in the ECG, which is called QRS complex. Every depolarization is followed by a phase of repolarization. Repolarization of the ventricles is represented by the T waves, which can be positive or negative. Atrial depolarization is depicted by the P wave, which is steeper than the T wave but flatter than the QRS complex. This tracing shows the ECG, which show the P wave, QRS, and the T wave. Now, what are the components of the QRS complex? As shown in this tracing figure, the first concept is that the first downward deflection is called the Q wave. Then, the second concept, any upward deflection is called the R wave. The third concept, any downward deflection that comes after an R wave and crosses the isoelectric line is called the S wave. The fourth concept, any second upward deflection after the S wave is called the R prime. Then, the fifth concept, if the entire QRS complex consists of one large downward deflection, then this is called a QS complex without R wave. Now, how can we identify the P waves, QRS complex, and the T waves? This tracing shows how can we identify each component of the ECG. As shown in this figure, this is a P wave. The first upward deflection is the P wave, then followed by the QRS complex. This is the QRS complex. Then followed by the T wave, which is more flatter than the P wave. This is a P wave. This is a QRS complex. And this is a T wave. This is P wave, QRS complex, T wave, then also P wave, QRS complex, and T wave. Now we will talk about the interval, which means the time, and the amplitude, which means the voltage measurements in the ECG tracing. This is a tracing which shows the y-axis components which represent the amplitude measurement. The amplitude represents the voltage measured in 1 millivolt each 10 millimeter, and the x-axis, which represent the time measurement or the interval, which is measured in 1 second each 25 millimeter. How can we measure the intervals in the ECG tracing? First, P-wave duration. It represents the time between the beginning of the P-wave to the end of the P-wave. This is the P-wave duration, which represents the time of atrial depolarization. This is the QRS duration, measured from the beginning of the QRS to the end of the QRS, which represents the time of ventricular depolarization. Measuring the PR interval from the beginning of the P wave to the beginning of the QRS, which represent the time from the first stimulation of atrial depolarization to the first stimulation of ventricular depolarization. Then the QT interval, which is measured from the beginning of the QRS complex to the end of the T wave. From the beginning, not the end, the beginning of the QRS complex to the end of the T wave. This is the QT interval, which represent the beginning of the ventricular depolarization to the end of ventricular repolarization, which is the refractory period. This is the measurement of the amplitude. This is an example of the measuring the S wave amplitude from the isoelectric line to the bottom of the S wave. This is the S wave amplitude, and also we can measure the R wave amplitude also from the isoelectric line to the top ending of the R wave. Regarding the duration of the P wave, depolarization of the atria, which represented by the P wave, usually takes less than 0.1 second. This tracing shows the normal P wave duration, which is usually less than 0.1 second, which is represented by 2.5 small square in the ECG tracing. If the left atrium is dilated, enlarged, depolarization takes longer and P wave duration will increase to more than 0.12 seconds, which means more than 3 small squares in the ECG tracing. What are the shapes of P wave? This is a table which shows the different shapes of the P wave. The first show the normal shape of the P wave. Usually we can check the P wave in the lead 2 or in V1 or V2. In lead 2, this is the normal shape of the P wave, and in lead V1 or V2, this is the normal shape biphasic P wave. In case of right atrial enlargement, the P wave will be taller in lead 2 and V1 or V2. P wave amplitude, which is more than 2.5 millimeter in lead 2, means that there is right atrial enlargement, which is called P pulmonale, because it is usually caused by pulmonary problem. Then we have left atrial enlargement, and this figure show the example of the P wave in left atrial enlargement, which is usually either biphasic or M shape. M shape usually in lead 2, in which the duration of the P wave is more elongated. So negative P wave in V1 more than 0.04 second. This is the negative, more than 0.04 second, more than 1 small square, and or P wave duration more than 0.12 second in most cases, which means more than 3 small square. This means that there is left atrial enlargement, which is called P mitrale because it's mostly caused by mitral valve diseases. Now we will come to the duration of the PR interval. The PR interval represents the duration the impulse takes to travel from the atria to the ventricles. It is measured from the beginning of the P wave until the beginning of the QRS complex, as shown in the figure, from the beginning, not the end, the beginning of the P wave to the beginning of the QRS complex. Usually the normal values are between 0.12 and 0.2 seconds, which mean between 3 to 5 small squares in the tracing. Any duration below or above this range is regarded as abnormal. This figure shows a duration more than 5 small squares. This is 8 small squares, so there is prolonged PR interval. This figure shows a duration which is less than 3 small squares, as in Wolff-Parkinson-White syndrome, in which the QRS immediately follow the P wave without a PR interval. QRS looks abnormal, as shown. There is delta wave, and QRS duration more than 0.12 seconds, usually widened QRS. This figure shows the second type of short PR interval, which is called Lone-Ganong-Levin syndrome, LGL syndrome, in which QRS immediately follows the P wave. Also, there is no gap, and QRS looks normal, not widened, unlike the WPW syndrome. The QRS duration also is normal. Regarding QRS duration, under normal circumstances, depolarization of the ventricles usually takes up to 0.1 seconds, as shown in this figure. How can we measure the QRS duration from the beginning to the end of the QRS complex? Dilation of the ventricles may cause a slight lengthening of the QRS complex, more than 0.1 second to less than 0.12 seconds, which means between 2 to 2.5 small squares in the ECG tracing. Significantly prolonged QRS duration more than 0.12 seconds indicates that either the right or the left bundle branch is blocked, which means any QRS duration, if it is more than 3 small squares, this means that there is a bundle branch block, either right or left. Wide QRS, which represent bundle branch block, when the QRS duration is between 0.1 to 0.12 seconds, that's called incomplete bundle branch block, which may be caused by dilatation of the ventricles, also referred to as volume overload. In case of complete bundle branch block, conduction through the left or right bundle branch is completely blocked, and the QRS complex is lengthened to 0.12 seconds or longer, 3 small squares or more. This figure shows the example of the left bundle branch block in which the QRS duration is equal or more than 12 seconds, which means 3 or more small squares, in which there is M shape over the left ventricular side of the precordial leads in V5, V6. This figure shows the example of the right bundle branch block in which also the QRS duration equal or more than 0.12 seconds, and there is M shape in the right ventricular side of the precordial leads, which means V1 or V2, and there is a slurred S wave in the left sided leads V5 or V6. Regarding the precordial leads, there is an important concept which is the RS ratio. As shown in this tracing of the precordial leads, this side is the right ventricular side and this side is the left ventricular side, which is shown that there is progression of the RS ratio in this tracing. Why is the RS ratio important? There are two very important laws that apply under normal circumstances, which mean when the muscle mass normally of the left ventricle exceeds that of the right ventricle. Law number 1, leads with an RS ratio less than 1 correspond to the right ventricle, while leads of an RS ratio more than 1 correspond to the left ventricle. Leads with an RS ratio equal to 1 correspond to the transitional zone between the right ventricle and the left ventricle, which means the septal part of the ventricle. Law number 2, under normal circumstances, the RS ratio increases as you go from the right to the left. What you need to know about ventricular hypertrophy: how can you diagnose ventricular hypertrophy from the ECG? This figure shows the different pattern of the ECG precordial leads. In case of normal ventricular wall thickness, we should notice the precordial leads. V1, V2 correspond to the right ventricle, as you know, and V5, V6 correspond to the left ventricle. This is the normal pattern. This pattern, in case of left ventricular hypertrophy, we have increased amplitude of S wave in V1, V2, and increase the amplitude of R wave in V5, V6, with STT changes in the left ventricular side of the precordial lead. In case of right ventricular hypertrophy, we have increase in the amplitude of R wave in V1, V2 with STT changes, and increase the amplitude of S wave in the left side of the precordial lead. Now, how can we diagnose left ventricular hypertrophy from the ECG? There are some ECG criteria of LVH. First, we have Sokolow criteria, which state that if we add R wave in V5 or V6, which one is longer, plus S wave in V1 or V2, which one is longer, as shown in this figure. If it is more than 3.5 millivolt or 35 millimeter, LVH is present. But this criteria is not sensitive, although it is specific. We have Cornell criteria, which state that if we add R wave in AVL plus S wave in V3, if it is more than 2.8 millivolt 28 millimeter in male, or more than 2 millivolt 20 millimeter in female, LVH is present. And we have modified Cornell criteria, which is simpler. R wave in AVL, if it is more than 1.2 millivolt or 12 millimeter, this may indicate that LVH is present. Now, what are the ECG criteria of right ventricular hypertrophy? We have the RSS criteria, which states that R wave in V1 equal or more than 0.5 millivolt, and RS ratio also in V1 equal or more than 1, and S wave in V5 equal or more than 0.5 millivolt. If two of the three criteria are present, RVH is probably present. If right axis deviation or an incomplete right bundle branch block is also present, the likelihood of RVH increases further. In the previous slides, we talked about the conditions that increase the amplitude of the QRS, causing high voltage ECG. Now we will talk about low voltage ECG. Low voltage refers to a situation in which none of the QRS complexes in the standard leads, which are lead 1, 2, and 3, is higher than 0.5 millivolt, i.e., all the QRS complexes in the standard leads less than or equal to 5 millimeter. What are the possible causes of the low voltage QRS complex in the ECG? First, we have severe myocardial damage like myocarditis. Second, we have pericardial effusion, especially if it is large. Third, we have pulmonary emphysema. Fourth, we have obesity. Fifth, peripheral edema. And sixth, hypothyroidism. How can we determine the cardiac axis from the ECG? The principles, we have this figure showing the Cabrera circle, which show the x-axis correspond to the lead 1. This is the 0 point of the axis. Lead 2 correspond to 60 degree, AVF correspond to 90 degree, and lead 3 correspond to 110 degree in the circle of Cabrera. Regarding the cardiac axis, we have the normal axis between minus 30 degree, which correspond to the AVL, to the plus 90, which correspond to AVF. This is the normal axis. Some references said that normal axis to 110 degrees centigrade, which correspond to lead 3. So we will take this as a normal axis between minus 30 to plus 90. Left axis deviation more than minus 30, and right axis deviation more than 90. In case of northwest axis, which is between minus 90 and minus 180 degree, we will take a simple measure to determine the cardiac axis from the ECG. This figure shows the determination of cardiac axis. If we find the QRS complex in lead 1 is mainly positive, we should look at lead 2. If lead 2 is also positive, this means that it is normal axis, which means the axis is between plus 90 to minus 30. If lead 1 mainly positive and lead 2 negative, this is left axis deviation, which means that the axis is between minus 30 and minus 90. If we find the QRS complex in lead 1 mainly negative, we should look at AVF, not only to lead 2. If it is positive in AVF with negative in lead 1, this is right axis deviation, which means that the axis between plus 90 to plus 180. If the QRS complex is negative in lead 1, 2, 3, and AVF, this is northwest axis deviation. So what are the causes of cardiac axis deviation? The causes of left axis deviation are left anterior hemifascicular block, left ventricular hypertrophy, and inferior MI. Causes of right axis deviation are left posterior hemifascicular block, right ventricular hypertrophy, and lateral MI. This figure shows the bundle of His and its branches into left and right bundle branch, and the left bundle branch, it's composing of two fascicles, left anterior fascicle and left posterior fascicle. If we have right bundle branch block plus left axis deviation or right axis deviation, this means that the patient have bifascicular block. What are the changes in the QRS complex in case of myocardial infarction? We have drowning in negativity. What does that mean? It means that certain parts of QRS complex become more negative, like Q waves, while other parts will decrease in size, like R waves, as shown in this figure. One or more of the followings can happen. Either a pre-existing R wave decreases in size, or a pre-existing Q waves get deeper, or a new Q wave develops. We have an important finding in the ECG that when it is present, it is always abnormal. This is the prominent R wave in V1. What are the causes? First, right bundle branch block, as shown in this figure, the RSR prime pattern. Second, right ventricular hypertrophy in the form of RS ratio in V1 equal or more than 1. Posterior myocardial infarction, as shown in this figure, it is the mirror image of the ST elevation and Q wave of the myocardial infarction. WPW syndrome, short PR with delta wave, as shown in the ECG figure. Fifth, dextrocardia with negative R wave progression in the precordial leads. We will come to the changes in the ST segment and T wave. First, we will take the ST depression and T wave negativity. You know that the ST segment is the segment between the end of the QRS and the beginning of the T wave. And the T wave shown in this figure is positive. Once you recognize the presence of ST depression or T wave inversions, you should look at two things. First, their location, which leads are affected, and second, their shape. This figure will show the different forms of ST segment depressions. We take the figure A, which indicate that there is ventricular hypertrophy, either left ventricular hypertrophy if occur in V5, V6 with a large amplitude R wave, and if occur in V1 or V2 with R wave, this corresponds to the right ventricular hypertrophy. The figure B show the downsloping ST changes, which indicate that there is digoxin toxicity or hypokalemia. Figure C show the horizontal ST depression, which indicate usually coronary insufficiency, which means that there is ischemia. Figure D show the upsloping ST depression, which is either due to sympathetic tone or hyperventilation or in coronary insufficiency. The figure E, which is deep ST depression, occur in severe ischemia. The following figure will show the different patterns of negative T wave. Figure A and B show the asymmetric T wave inversion, either uniphasic or biphasic. Asymmetric T wave inversion usually occur in the setting of ventricular hypertrophy, while in figure C and D show the symmetric T wave inversion, either uniphasic or biphasic. Symmetric T wave inversion usually occurs in the setting of myocardial ischemia or myocarditis. Now we come to the types and causes of ST segment elevation. You know, the most common cause of ST segment elevation is ST elevation myocardial infarction. This figure shows the phases of myocardial infarction. Phase 0, peaking T wave. Phase 1, the appearance of ST elevation. Phase 2, in addition to the ST elevation and negative T wave with the appearance of Q wave. Phase 3, the regression of ST elevation with large Q wave. Phase 4, the Q wave still present and no ST elevation. We have the second cause of ST elevation is the Prinzmetal angina, which is transient ST elevation less than 20 minutes. The third is LV aneurysm, in which the persistence of ST elevation after myocardial infarction for more than 3 weeks. 4. Left bundle branch block, as shown previously. 5th, pericarditis, as shown in figure. The ST elevation of pericarditis is a concave shape, while the ST elevation of myocardial infarction is a convex shape. 6. Hyperkalemia, which can cause peak T wave with ST elevation. 7. Brugada syndrome, as shown in this ECG tracing, ST elevation in V1 and V2 with T wave inversion. And vagotonia, which is called early repolarization, as shown in this figure, usually occur in young male in V2 and V3. How can we measure the QT interval? And what's the normal QT interval? There are two approaches. The first, the corrected QT interval should be normalized for a heart rate of 60 beats per minute. Most ECG machines will calculate the QT corrected time. The QT corrected is prolonged if it is more than 0.5 0.44 second in men and more than 0.46 second in women. While the quick method, we can use it if the T wave ends in the first half of the RR interval, the QT interval is normal. That's to say, less than the half RR interval. If the T wave ends in the second half of the RR interval, the QT time is prolonged. That's to say, if it is more than half the RR interval. So what are the causes of prolonged QT interval? First, congenital long QT syndrome. Second, electrolyte abnormalities such as hypocalcemia, which is a common cause of prolonged QT. Third, drugs. We have many drugs causing prolonged QT interval. Of them are antibiotics like macrolides and quinolones, antidepressant like tricyclic antidepressant and selective serotonin reuptake inhibitors, antipsychotics like haloperidol and phenothiazines, antiemetics like ondansetron and prochlorperazine, and antiarrhythmics class 1A like quinidine, procainamide, and disopyramide, and also class 3 like sotalol and amiodarone. Lastly, what are the ECG changes caused by electrolyte disturbances? ECG changes in hyperkalemia is characterized by a tall and tinted T wave, which is called peak T wave or tinted T wave, and in more severe cases, the P wave also gets lost and the QRS complex gets broader, as shown in the figure. ECG changes in hypokalemia are flattening of T waves and appearance of a U wave in addition to ST depression, as shown in the figure. But notice that do not confuse the QU interval with the QT interval, because hypokalemia does not cause prolonged QT interval. The second electrolyte is calcium. In hypercalcemia, the QT interval can be shortened, whereas in hypocalcemia, the QT interval can be prolonged, as shown in the figure. The first show normal QT interval in case of normal calcium. The second show prolonged QT interval in case of hypocalcemia, and the third show shortened QT interval in case of hypercalcemia. I hope you enjoyed this lecture. Thanks for listening. Meet you in the part 2 and goodbye.